Dr. George Joseph will be showing about aortic aneurysm stenting, AAA stenting. Most of our colleagues requested. He is the one who has the maximum experience in the country. That's how we requested him to perform.
Yeah, so today's case is quite a challenge. This is the oldest case we are ever going to do or ever have tried. And it's a 90-year-old male. He's a hypertensive and smoker. And his creatinine is 1.2, which translates to a GFR of 25. That brings him into chronic kidney disease stage 4 actually. So we need to restrict the amount of contrast we use in this case. He has a 7 centimeter infrarenal abdominal aortic aneurysm, and there are two challenges here. One is it has a very angulated neck, and the second is that his iliac arteries are very tortuous. Next slide please. This is a 3D reconstruction of the aneurysm and the iliacs. You can see the angulated neck on top and the very tortuous right common iliac artery below. The left common is fairly straight. And there is a lot of calcium all over the vasculature, so that could also pose a problem at times. We have already done an angiogram a few days ago. This shows the neck. You can see a very, very sharp angled neck. The landing zone is almost horizontal, and below that we have a bend which is more than or less than 90 degrees. It's something like 70-degree angles, which is strictly off-label, I'm told. This is not being advised as an indication for endovascular, but we have decided that this particular anatomy needs something very conformable, so we have chosen the Endurant device today. Next slide please. Yeah, that's the picture of the aneurysm, and you can see the very tortuous right iliac. Next slide please. Yeah, that's the wire which went through the right iliac on that day. It took some doing to get catheter through. You can see the calcium lining the wall of the aorta and the iliacs. And the next slide please. Yeah, this is the top end of the neck, just at the level of the renal artery, and it measures 25, 20 or something like that. So we need to oversize by about 15%. So we'll have to choose a device that's rate 28. And next slide please. And these are the common iliacs. The left is about 18 millimeters and the right is 20. Both are slightly ectatic. So the left iliac being straighter, we are going to introduce the main device up the left iliac, and the lower end of the main device will taper down to 20 millimeters. So it's oversizing by 2 millimeters on the left common iliac end. And then we will add on the contralateral limb, which will have to be more than 20. So we're going to choose a 24 lower end of the contralateral limb. And now to get our top landmark sorted out, we have actually got a brachial axis, and just pan the table. I've got a catheter there. It is actually, I had a wire in the left renal artery, which is the lower of the two, but unfortunately the wire has slipped out while I was talking to you. But the catheter is still there, so we can actually test from there and know exactly where the top end of the device should land. And I'll just show you the lie of the very stiff catheter. See, it has straightened out the curves down the iliacs. And at this stage we are all set to go in with the device, and I would like to know what the views are of the panel and the audience.
Yeah, can we have Sushil and Mac on the dais? Because our Surgeon Gupta is not there. I request them to come on to the dais. And can you repeat and show us the angio picture once again? Can you see that angio picture which you have taken?
Yeah, we don't have the running angio picture. We can just show the slide. Go back to the slide number 2.
Achha, because of contrast issues, I think you didn't take. One important point which he brought out is though creatinine is 1.2 in an elderly person, thin built, it becomes very important. GFR, when it's calculated, it's 25. So it's a point to be noted by when all of us deal with sicker patients. You just don't go by creatinine, you need to assess for eGFR.
Next slide 2.
Yeah. Dr. Hiramat is joining
slide,
us.
Okay, slide 3. Slide 3. Yeah. Okay, so that's how the neck looks. If you look at it carefully, the left renal is slightly lower than the right. And the left renal on fluoroscopy is at the L1, L2 intervertebral disc. So if we land the device starting at the top of the L2 vertebral body, I think we should be fine.
Does this anatomy change now that you have the stiff wire in terms of trying to position and the landmarks? Is that, and you primarily going just on the wire that you have in the renal as your marker?
Yes, the anatomy does change. The curves all straighten out. And finally, when you take the wire out, the device then conforms itself to the anatomy a lot more. So we cannot go by angiographic landmarks which have been acquired earlier. We have to test using that catheter up there to be sure that we are not covering the left renal artery.
What was the length of the neck on the CT?
I beg your pardon?
How long was the neck
The
on
length of the neck.
Yes, please.
Yes. See, from the left renal to that bend over there is roughly 4 centimeters. You can see the marker pigtail, each of those are 1 centimeter. So we have actually done an angiogram today, which I will show you. Can we run today's angiogram? See, we are using carbon dioxide to reduce the volume of contrast used. So today what I did is I put the marker pigtail with its stop marker at the left renal, and then I looked at the lower end and shot carbon dioxide in from the sheet. And can you see the running carbon dioxide angiogram? You see carbon dioxide entering the iliac from the sheath, and you can see the iliac bifurcation is roughly between the third and the fourth marker from the lower end. So that translates to a total length of about 170 from the lower renal to the iliac bifurcation. Of course, it will probably be even longer because the anatomy is even more tortuous. The device will accommodate itself. So I'm going to take a 170 millimeter long device, which is 28 millimeters on top and 20 millimeters at its lower end.
Which device are you going to use with that kind of angulation?
Yeah, we've chosen the Endurant from Medtronic, so maybe we can show them the device. Just bring it onto the table. This is the Endurant device. It's quite simple to use. You can see the stent graft loaded in here. That's the nose cone, and this device has barbs on its top outer aspect. So when it opens, those barbs sink into the wall of the aorta, and those barbs are constrained by this capping system. And this capping system is released by rotating this knob over here. If I rotate it clockwise, the barbs will open out and fix onto the wall of the aorta.
So this is the new one with suprarenal fixation?
Back and forth. Actually, this has some bare stent on top, which is going to be above the renals. So this does have suprarenal fixation. Yes, you're right. So if it's okay, we will proceed with bringing this device in. And this sheath we will remove, and Edwin, you will keep some light on there.
What size sheet does it go through?
It doesn't go through a sheath. We take it bare over the wire. We've got a cut down done in both grinds. Both the femoral arteries are exposed. And the size of this device is 20 French, which is about 2 French down from the older Talent device which Medtronic had. Similarly, the contralateral limb is either 16 or 18 French. Today's will be 18 French, but it's 16 or 14, and today's will be 16 French. Okay, so you can follow the device going in now. We are using a backup mere wire, which is a very stiff wire, and we have now reached the level of the renal artery. So you'll have to give me a test from there through that side arm with some contrast. Yeah, so the device has to be oriented such that the contralateral limb points to the right side of the patient, because we're going up the left side. So that is indicated by a dot here. So I will rotate this so that the dot faces right side. So it's now facing to the right, and you could also see the contragate markers in the middle of the device.
So the
Okay,
first
now
marker
we'll
is the
focus on
flow
the left
divider,
renal
and the
artery.
second is the contralateral limb. Is that correct?
That's correct. There is one set of markers where the covered portion starts right on top. Then there's a marker at the flow divider. Then there's a marker at the tip of the contralateral limb. No, hold it. One sec. All right. So I'm now at the level of the left renal. We'll have to now take a picture here. Remove subtraction. Remove subtraction, and we'll just you inject a nice 5 to 10 ml. Okay, we'll take a picture here. Yeah, so you can see that we are exactly at the renal level. The left renal artery is where those dots are, and that's where the covered portion starts. So I will start the release here, and then I still have the option of moving up and down a little bit if I want to. So the release is by rotating this blue part of this device anti-clockwise, and then you will first see the bare spring opening up. It has opened only partially. I think what's happening is that there is a constraining effect of the aorta on the device, because the aorta here is actually horizontal, and we have got it straight with the stiff wire. So the part of the device that's open is not as open as it normally is. Okay, so I'll continue to release the device. Yeah, now it's opening a little better. Now we'll take another picture just to see how we are doing with as far as the renal is concerned. Yeah, we're still okay, but the challenge now is that, we've got that neck of the aneurysm vertical, which is shortened the length very much. So I'll need to kind of graft in as much as it will go while I'm deploying this, because I've already got past the neck. The conjugate is still yet to. So it may end up being too low down, in which case I will have to put a small aortic cuff on the top side, which is looking like that's what's going to happen now. Because we've already reached the inside of the aneurysm. No, just keep it like that. Shall I release the... yeah. Okay, so now the contragate is open, but most of the device is actually in the sac of the aneurysm. There's only very little in the neck, which is, it's in the, although it looks at the level of the renal when you test, there is an angulated neck which is straightened out a lot, so I'll have to use a cuff on top. So now I'm going to release the nose cone on top. Can you show the top a little better? I will just take one more test shot there. Yeah, the nose cone, I mean the covered part is still okay. It is starting just run that again. Yeah, the left renal artery is still flowing, but when this opens, it could open onto the left renal artery, or sometimes it could open downwards also. It's difficult to predict what the final lie is, but if I try to come down, then I'll lose the sealing as much as possible. So I'm going to now release the barbs of the device by rotating this knob here.
Can you leave the wire in the renal while you deploy, or will that be more dangerous trapping it like that?
I didn't hear that.
Is it possible to leave the wire in the renal
Pardon?
that you had earlier, or you can't deploy the device with the wire there?
Actually, I had the renal wired, but the anatomy is such that it's very difficult to have a stable position in the left renal artery. So I can't. If I want to wire the renal, I'll have to do it from below, and once I've opened the device. Of course, if necessary, I may have to do it from top if I've jailed it. But I think I'm still okay. Maybe we can just do one more test shot and decide whether we. Okay. Yeah, I think we're okay. The left renal is still flowing. So I'm going to complete the release of this. So I've now released the barbs. The bare spring part is opened out. This is fine. So now I'll finish the release of this device and just see if it's possible to. Can't pack it in anymore. So now I'm going to release the ipsilateral limb. I can probably do it under.
George, Dr. Hiremat.
Yes, Hiremat.
Yeah, I saw you being very careful about the renal artery origin. Is there any way to sort of adjust the positions once a few inches have already been opened up? I guess, I'm asking a question because I'm not very sure. You couldn't have adjusted the position anyway.
You could have adjusted the position even after releasing a few steps.
Here in this case, I was unable to adjust upwards once I started the release. I think it's something to do with anatomy. It's almost impossible to move it up, because what has happened is that the neck is actually horizontal and the stiff wire has made it straight, vertical, and has also shortened it a lot, and it's not possible to pack that thing in. I think it may pack better when I balloon it subsequently. This is coming off. So I think I'll now take out this delivery system. Yeah, so for that I will show the top of the device. Yeah, take the device a little up, free of the barbs, and then I will rotate this the opposite way, so that the cone on top is onto that black knob. Okay, now that is done. Now I have to pull the nose cone back into the sheath. Hold this wire, please. And I hope that it won't grab the device, which could well happen given this anatomy. So the one way to do it is to rotate it down.
Can we see Flora, please?
Yeah.
Can we see fluoro?
Can you see fluoro now?
Yes.
Now we can.
Yeah, so I've got the nose cone coming down, and it has now reached the sheath at the lower end. Show the lower end, please. Yeah, when your hand is on the fluoro. So we have got this device through, and what I'll do now is we have to see what's happening on top. And probably we need to balloon that to make it, conform better, and then decide about the next thing.
So how did you
So I'm
manage
going
to
to
get the
remove
nose cone down? Just by rotating on either side?
Yeah, I just rotated the entire device as I was moving down, and so it slipped off those barbs. Is that okay? Maybe we can put a sheet there, no? We can clamp it. It's a 24-pin sheet.
What are the
Get that
options
sheet.
just for the panel? If in case if we have the
Get that
cloth
sheet.
coming across the mouth of the renal,
Just
what
flush
would
that
be
sheet.
your options?
I couldn't hear you.
If the cloth-covered portion is facing the ostium of the renal artery
Get the sheet.
after deployment,
Just bring it here. No need to.
You could consider tunneling, get a wire behind it into the renal and put a stent, so you could create a tunnel into it. It would be one option, I guess.
What was the question?
If the cloth portion is above the renals, what are your options at that point?
Yeah.
Try and come from above is what I would think. But.
Yeah, I mean, that's why you have that proximal part constrained, so you can avoid that, because, for those of you who aren't
So I'm
familiar
gonna
with
come
it, the
out,
upper
then
stent
go
struts
into
are
the-
actually not covered with fabric, so you're not going to be covering the renals there. If you cover it late, you can try to poke through it, come from behind it, or operate if it comes down to it. But it's obviously, like he discussed before, he'd almost rather be a little low and put in a proximal extension than have exactly that happen. It may be also, there's some straightening artifact here with the stiff wire, and if you were to have I think it does need to be post-dilated, but if you were to put a softer wire, it might reorient a little bit as well.
Would leaving a wire help there? Leaving a wire in the beginning into the renal,
Just
that
hold
may
that
also
there.
help here.
Okay, the quota balloon.
Reliant.
Reliant. So we're going to bring in a balloon, the Reliant balloon. it's a very compliant balloon. It can be dilated up to 40 millimeters. And we just use ordinary syringe for that.
One question that was raised by the panel is there an advantage to maybe putting a catheter and taking out the stiff wire to see without the stiff wire what the anatomy does before doing anything further?
Yeah, that's a good suggestion. But I think before that I'll do the ballooning so that, you know, it conforms better. And then I'll change the wire and see what it looks like.
I think the balloon should go on a stiffer wire because
Yes,
the balloon
yes.
also might find
Put it
some
on the
resistance.
wire. Come, you take it. Okay, so we've got the Reliant balloon going in. This earphone keeps coming off. Good. Hold the wire, please. Just follow the balloon coming in. It's snugging that inner end of that device, which is very kind of constrained by the straight. Came out? Okay, you'll have to hold it, and it won't go in that easily. You'll have to come back. You want to put it back in? We can do that. Just hold the wire, please. No. Yeah, okay. I think the sheet has slipped out, so I'm going to remove this balloon, put the sheet back in, and then we'll go back with the balloon again.
You think if the wire was not
Okay,
that
just-
stiff, it would have gone?
I think that's what we're just discussing here, that there's
Possible.
maybe a pseudostenosis from the
Yeah.
stiff wire and maybe contributing
All
to it as
right.
well.
Yeah, I mean, it's
Okay,
clearly
all right,
creating
then
an
I'll-
angle
I'll,
between the device and the wire.
Yeah, so first we will put the sheet in, then we'll take the 6F guiding catheter. What I was doing was to put a 6F guiding catheter which has some stiffness to allow this backup wire to go in. When I used a flexible 5 French pigtail, instead of the backup going in, the pigtail came out. So I wasn't able to get the backup into the arch of the aorta. So we'll keep that nicely showed down there.
George, why not try sending the balloon on a softer wire and not a very stiff wire?
Yeah, I'm going to do that. I'm going to do that. So what I'll do first is to put a catheter up,
And
then change the wire,
Because
and
that's
then.
correct.
Can you give an amplite super stiff? Yeah, okay, so I'm going up here.
I know. Where is he?
Follow it up, please. Leave the wire. Leave the wire. Yeah. Okay, get the amplites, please.
Can we just see what the graph looks like with just without the wire in, just fluoroscopically, no angio?
Yeah, okay. Just pan the table down to. It's much the same. Okay, just follow the wire, please. All right.
Which wire are you
But this
taking
is
now?
this is an Amplat super stiff. it's a little less stiff than the backup wire. But if this also doesn't work, I may have to try a two-wire technique. I'll put a soft wire parallel to this wire and then get the balloon over the soft wire. Yeah, so it's got past that point. And I must remain within the covered portion. So, okay, so we'll very gently start the inflation to keep it pushed up a bit. No, I think I'll have to go up further. This is... Yeah, okay, just inflate a bit.
It has to go higher, yes. Otherwise it will just blow.
Okay, just go down again. Yeah, just 1 minute, slowly. Because we're over the mouth of those vessels. Yeah, okay, gently go up.
Probably, yes. The crossing is a problem here. Runway is taking shorter than longer.
Okay, deflate.
More difficult to turns, to negotiate turns.
Which balloon is this again?
Reliant, the Reliant balloon. Okay. I know, but it won't expand that part. Okay, just go up again.
Now it is sitting.
Yeah, I think that is some sort of expansion that we've got. But it's still not very molded to the way the anatomy looked to start with. Okay, just go up again. Okay, down. Okay, one more time. No, down. It's still too low. Okay. All right. So now what I think I'll do is I'll get the stiff wire out, put a soft wire there, and then maybe do an angiogram and see how things are. So I think we'll put the pigtail, just get the pigtail.
Plate picture.
Is it coming out? Get the injector.
Yeah.
All right. Injector. We'll need a breath hold, please. Give 20 at 18. We'll focus a little higher up. Yeah, okay. All right. Ready to go? Breath hold, please. Okay, breathe on, please. What we've got here is that the top of the device is not opposed itself to the wall, especially on the right side. So I will have to use a little more force to try and expand that over there. Because otherwise, putting another device is not going to solve this problem, because that will also be constrained within this device. So we'll put back Amplatz wire, and I want an Atlas balloon, 18 or 20. Give the Amplatz wire again.
Are you going to take a bigger and longer balloon?
Beg your pardon?
Are you going to take a bigger balloon?
No, I'm going to use a non-compliant balloon to try and expand that device, so that it gets apposed to the wall a little better.
It looks like a lot of it may just be constrained by the angulation, because that's pretty extreme there, as you noticed before. But for what it's worth, it didn't look like the sac was filling either.
Do you have Atlas? Yeah, 1840. Okay. Just look for a 20 also. Okay, come. Oh no. We'll have to hang on till I come.
You have less than a minute of transmission now to be shown here.
Yeah,
So we are interested to know what is the final result.
Maybe give you a... Yeah, okay, we'll have to do that.
We may be able to stay
Okay,
a few minutes
just,
longer, but if we cut out, I want to thank you again for this demonstration. Maybe quickly could just
Okay.
tell us what your plan is going to be in case we do get cut out.
Yeah, I'm going to try and expand this and make it apposed to the wall, and then maybe put another device on top, or maybe even a PAMA stent, so that it has a lot of radial force to help it sit there. And then I have to ensure that I've got a good seal on top. And after that, I will extend the contralateral side and finish. So the key is the top end, the neck, and deflecting. As you can see, I've got a little bit of expansion with this, but I'll need to keep going with perhaps a bigger balloon and then take an angiogram again. Yeah, so we'll put that sheath back in. It slipped out. You have the dilator of that? The option really would be a PAMA stent to expand and oppose to the wall.
What are the issues if we leave it as it is? We worry about the endoleaks at that
I
point?
don't think we've got a good seal. See, unless we have a seal on top, we really haven't achieved our objective. So we'll have to keep working till that top end is fixed, and then then only we can proceed further down. Yeah. After that, there are 24 also, no? Get a 24.
I think, unfortunately, with this kind of angulation, sometimes you actually usually won't get a perfect result, and it might be worth getting the rest of the components together and determining if you have a leak.
Okay. But the top leak we could make out even without, but that's a good suggestion. We can do that. Okay, let's go up. 3, 4.
this time he has taken.
So this is a bigger balloon?
Yeah, this is a 20.
Yeah.
Okay.
So what is this? This is
Yeah, at least we're looking like we're getting the top of the device open. And we will have to keep working till it's, apposed completely circumferentially around onto the aorta. And then we will continue with procedure further down. So what's the next balloon we have? Do you have a 24 or a 22?
So what do you think opened the waist? Is the oversized balloon?
No, it's not oversized yet. It's the aorta we measured as 24, and so we actually took a 28 device. So we still not reached the full size of the aorta there. So we'll keep going till 24, and then we'll see what we can do after that. Do you have any 24? Jomiva 24? Or this Maxi LD 25? Is there a Maxi LD 25? I think that's it. We can take that. Yeah, we'll use that. Yeah, we've got a 25 already.
So this is a 22?
No, actually, I don't have a 22. I'm going straight up to a 24 now.
Okay.
Okay, let's start. What's that? All right, go up. You have enough contrast, you run out of contrast. Okay, deflate, you get more contrast. You don't have enough contrast in this syringe. Okay, release the negative. Get some more fluid. Just saline will do. Come. Yeah, it's okay. Okay, negative. All right, go up. Yeah, what are you at?
Can we see fluoro again?
Oh, we lost the fluoro.
That's all. You don't have more fluid. Okay, down. We've run out of fluid again. This is a very voluminous balloon. So you probably need a larger, we can maybe just try a handheld inflation syringe with just very dilute. Okay. One sec, I'm a little too far up. Yeah, okay. Yeah, okay.
How much of your balloon's in the ipsy limb there?
Beg your pardon?
It looks like some of the
okay,
balloons in the
part of it
ipsilateral limb.
It's just about the conical part is there, yes. The whole length of the covered segment is supposed to be 5 centimeters, and this balloon is only 4, yet it has a long shoulder on both sides. All right, we'll take the balloon out. Maybe now we'll repeat the angiogram and reassess what's happening.
To create a good seal at the top, what are the options? One is to get a full expansion, whichever way. You would get it with balloon or maybe an additional stent. And occasionally another device too.
I mean, I think the options are another device, but as Matt was saying, there's not much room with that renal to add another, a cuff. A palmar stent would potentially help this radial force and strength on that angulation, and maybe just change the anatomy enough by straightening it with some more rigidity to get a better seal. I think those are the two primary options at this point. Although obviously ballooning has been done usually.
Yeah.
So if renal position was not an issue,
Same thing
another
again.
device can be an option.
Yeah.
We'll need a breath hold, please. Is it holding?
No, it's fairly good.
Breathe on, please. Well, it looks more expanded,
Yes.
and I don't see a para device type 1 proximal leak.
There does appear to be
I think it looks great.
So maybe I will just now proceed and put in the other components and then see whether at the end of it there is a leak at all.
I think we probably have about 5 minutes left here at most, so we'll stay with you, and then if we can for a little bit, and then we may end up getting our satellite cut.
Okay. Thanks for being with us and all the suggestions. Give me back
Thank
the
you.
Amplats wire. I'll just.
it's already more than 1:30. Next session is another lecture. It was by himself. This lecture had to be with him. He had to be together, but just joined me.
Okay, now I'm going up. Show the arch.
Yeah.
Okay, it's going. I know. I need to. Yeah. Now we have to put the backup, but before we do that, I need to get this catheter nicely up. Okay, get the backup now.
Chaotic informations, current status.
So the next thing we have to do is to cannulate the contralateral limb gate. So I've already got arteriotomy on the right groin, and there's a 7 French sheath in place. I'll take a Judkins JR4 curve catheter and try to go up the contra gate with a Termo hydrophilic wire. Just show the lower end, the contra gate now. Yeah. Okay. No, we had one. Oh, it's there. We don't need that anymore. We'll take that out. No, it's okay. We'll use this. We can take that off. Yeah. Just take the wire out and get the thermo wire in. Can we run the last angiogram while we are watching this? Yeah, we've got the visceral artery is still flowing well in spite of all that balloon dilatation. I was worried that, because the balloon was above the covered part, it might traumatize the aorta and the ostia of those visceral arteries, but fortunately that doesn't seem to have happened. Actually, according to the recommendations, the balloon dilatation of the stent graft should be completely within the covered portion. But here we really had no choice. That's the only way we could have expanded that constricted portion on top. Okay, so now we're going up the right iliac artery. You can see it's so tortuous there. I'm getting a catheter up. Now I need that talking device. Now I've got an advantage here that if I fail to cannulate this gate, I could come down the right brachial axis, which I already have, and try to snare the wire out from below. I need a vertebral next. This doesn't work. You know, I'm working through a very tortuous iliac, so it's difficult to get control of the wire, not the wire, the catheter. No, it's not in. Can we change the angulation to get that contra gate opened out as much as possible? No, the other way. Yeah, keep going. Just watch out. Yeah, a little more. All right, so we've got the contra gate opened out a little better, so we might be able to direct our wire there. But remember, this is in 2 dimensions, so we could still be wrong in the 3rd dimension. Do you have a straight wire? I think it may be easier to just come down from above. Yes, it's in the sac from here. But I'll just give it one go with a vertebral catheter also. And any suggestions from the panel how one could cannulate this gate easier? Can you give me another view? Just go to go a little more extreme. Yeah, okay. Pattern, out. It's out. All right, we'll change the catheter. You got the vertebral? I'll keep this wire there.
Because the option, as you said, is to come from above from your brachial access. And you can.
Yes.
Would you then snare the wire next to your eyes and use a catheter, or?
Yeah, there are 2 options. One is to keep a snare just under the contra gate, or the other is to just send the wire down the iliac and then snare it in the iliac artery. So just hold the wire, please. It's loose. Meanwhile, you get that JR ready to go in from the brachial axis. Okay. Yeah, you can. Let's look at it in the RAO view also. Maybe we are not right in the direction. Yeah, this tells us that we're way off. We need the talking device, please. Okay, I think we'll now move to brachial. We've given this a reasonably good try. It is not working, so I'll get us a 6 French snare also. Okay, let's check in LAO view.
Oh.
15. We'll put that from this side. So I'm going to position a snare in the sac of the aneurysm just below that contra gate, and I think and then bring a catheter in from the brachial side.
So I think we're going to have to leave you for now, but I guess your plan will be to go for. Do you want to just briefly tell us what the next steps will be?
Yeah, we need to get a wire in from the right groin up into the aorta through the contralateral limb. Then we will measure the distance from the contralateral limb to the iliac bifurcation, and then choose a device that is appropriately long to land just proximal or above the iliac bifurcation. Once we deploy that, we'll balloon the overlap zone of the contralateral limb with the contralateral stub, and also the distal end of both grafts, and that should be pretty much all we have to do, and then just the final angiogram.
Great, thank you. I want to thank you again for this excellent demonstration. It's a very complex and challenging case, and thank you for taking time to do it live for us.
Those of you who did not see the initial bit of the case, he was a 90-year-old male with a large intrarenal aneurysm. And this is a picture of the aneurysm. It had a very tortuous iliac artery, especially on the right side, and a very angulated neck. And this was the angiogram baseline. You can see a very, very angulated neck, which was a real challenge as to how we are going to deploy the device. And we used an Endurant device, and this was the picture after we deployed it. It looked very bizarre, the way the top of the device is not opened out, and it looks very angulated over there. And yeah, so we at this stage decided that we would try to expand that neck as much as possible. So we serially dilated the neck with larger and larger balloons, and we used not the usual compliant balloon, but which is seen on the left of the screen, but non-compliant balloons, and we went up to 25 millimeters. And you can see that that neck is straightened out, and the device looks more the usual kind of appearance when it's deployed. And this is the angiogram immediately after that. You can see that the top of the device is just in the right place below the left renal artery, which is the lower of the two arteries. Then we proceeded to cannulate the contralateral gate, which was difficult from below. So we actually passed a wire down from the brachial artery and snared it out from below. And this is the first contralateral extension that we deployed, which was 24 millimeters at the bottom. But we felt that it was a little too short, and so we extended it with another device, which was another 2 centimeters long, and this was more satisfactory. So this was, after that we balloon dilated the ends of the device and the overlap zones, and we got this final result. You can see that there is no endoleak at all, and all the visceral arteries are flowing well on top, and the device looks pretty well anchored. Those barbs are now digging into the aortic wall on all sides, and the lower end of the aneurysm looked like this. You can see the two iliac extensions going all the way up to the iliac bifurcation. The internal iliac arteries are patent on both sides. On the left side, there is a little bit of a narrowing at the aortic bifurcation, but that did not have any hemodynamic consequence. This is probably because there's a double device on the right side and a single device on the left, so that the radial force exerted on the right is probably compressing the one on the left, and there is a limited area within which these two limbs can sit. So this was the final result. Again, no endoleak, and both bilaterally flowing external and internal iliac arteries. So this is the still images of the last angiogram that we took, and it looks pretty good considering the anatomy that we started with. After that, we extubated him and moved him to the ICU. He is conscious now, oriented, neurological deficits, and the blood pressure in both the lower limbs is exactly the same, 150 systolic, showing that narrowing which we saw angiographically was not of hemodynamic consequence. And then he's passing a lot of urine. You may recollect that his GFR was only 25 ml. So he's doing well, and I think they are achieved the objective we set out with. Thank you.